I'm just letting people populate into the meeting. I'm not sure what they can hear until they, for a few minutes, so we'll just let that the group join us before we welcome people. And Dr. Taylor, your lighting is much better. Thank you. And with that, I will say we have quite a few people with us from around the state and country as of this time. Really appreciate everybody coming together in the great cause today of driving down preventable disabilities and death from diabetes in particular and cardiovascular disease. We have wonderful leaders from around the country with us. Dr. Oliver Brooks, welcome from the Los Angeles region.
Thank you.
So we have with us also leaders from New York, Chicago, Travis Air Force Base, the state capitol, and one of the top performing medical groups in the country, Palo Alto Medical Foundation. So thank you to our presenters from the state of California, and thank you to our sponsors from the state of California. We've been working arm in arm with state officials since 2006 when we first launched this program. This is approximately our 292nd event of the Right Care Initiative since our launch. And we would not be here if it weren't for our wonderful sponsors from the UC Berkeley School of Public Health, the California Department of Public Health, the Los Angeles Department of Public Health, Blue Shield of California, the Stroke Awareness Foundation. Several individual families are now supporting us. Very grateful for the improved care their families are receiving. We have a representation from really across all of the University of California and leadership with us from the University of California, San Francisco, and Stanford, and the California chapter of the American College of Cardiology, in addition to the Health Trust of Santa Clara County. We are so grateful, all of us, to be alive and standing, in part due to the incredible biopharma industry that helps to support this work. Johnson & Johnson, Genentech, Novo Nordisk, Boehringer Ingelheim, Amarin, and Amgen have been essential supporters of this work. And we're also supported by amazing volunteer leadership from not only the state of California, but now increasingly some national members. Next slide, please. The goals of the Right Care Initiative, for those of you who have been with us many times over the last more than a dozen years, are basically that through controlling the three metrics of cholesterol, blood pressure, and blood sugar, we have had good success in driving down particularly acute myocardial infarctions in one test community where we were able to apply a great deal of energy thanks to an NIH grant. So we have gathered 4 communities across the state of California, first San Diego, then the capital region, then Los Angeles, now the Bay Area. And we are actually, now that we're using the Zoom format, we are able to take this work broader to other states around the country. Next slide, please. So we use a framework of driving improvement through competing against disease and not each other. And we use data to help us drive that. We invite the top performers to teach how they did it. So you'll see on this slide, the very final tall gold bar there is the percent of patients in good control in Santa Clara County within the Palo Alto Medical Foundation medical group. And that's really quite impressive, with 71% in good control for all hypertensive patients and 79% for diabetic patients. So we have with us Dr. Ed Yu. Ed Yu is the Chief Quality Officer for the Palo Alto Medical Foundation, who's overseen this really important work and helps to lead our Bay Area group. So with that, I'd like to hand the mic over to Ed Yu to take us through the rest of the agenda. So welcome everyone, and thank you to the 292nd session of the Right Care Initiative.
So good afternoon, everyone. Thank you very much, Hattie, for that warm introduction. And on behalf of the Silicon Valley chapter of the Right Care Initiative and the leadership team, thank you all for joining us today. We do have a wonderful program in place over here. It is going to be a data-driven session today, and with a focus of looking at various disparities, and also we're going to learn a little bit about some interventions and some of the groups are doing in this space. And I hope that this will, I believe this should trigger a lot of thought. So I would encourage all of you to leverage the expertise we have here today to ask questions. And we have catered this agenda that we should have good discussion time. We will, for those of you who want to, feel free to put comments or questions in the chat. I'll be monitoring them and ask our speakers as we go along. And I believe, Hattie, there's provisions also for people to ask questions live on the air as well, and she's confirming that. So this is our agenda over here. Without further ado, we'll dive in. Any other program notes from the Right Care Initiative team that I need to know? All right. Well, on that note, our first speaker gives me great pleasure to introduce Catrina Taylor. She, as you can see, nice smile. Her title, she's the Chief of the Health Information and Statistics Section with the Chronic Disease in the California Department of Public Health. And I had a great chance of kind of knowing her and her wonderful personality during the prep sessions. She holds a PhD in Public Health Policy Analysis from the St. Louis University. And she's full of energy. In the prep session, we kind of ask her what are some of your guiding principles, particularly in times of COVID? And she mentioned to me that you can tell the audience that no matter what, I see the silver lining in everything, which is great because she's going to talk a little bit about health disparities, and we know there's wonderful gaps that we need to close in that space. And I hope that we'll all learn a lot from Catrina. So without further ado, I'm going to pass the floor to you, and we look forward to your session. Thank you.
All right, thank you so very much. All right, my topic for today is disparities in cardiovascular disease and diabetes in California. Next slide, please. So cardiovascular disease, there are approximately 12 million Californians affected by cardiovascular disease. And the most common forms of CVD are heart disease, heart failure, hypertension or high blood pressure, and stroke. Next slide, please. So the prevalence of the common forms of CVD by race, you'll see here we have 2019 data from the California Health Interview Survey. And the dotted line is the average prevalence for all of the conditions or all of the areas. So the ones that are above the dotted line are, for heart disease, it's Caucasian Americans, whites. For heart failure, it's African Americans, American Indians, Alaskan Natives, and then also Native Americans. For stroke, it's African Americans. And then for hypertension, you have a larger group there. And you see African Americans, American Indian, Alaskan Natives at 37%, and then Native Hawaiian and Pacific Islanders at 43%, and then also whites at 29%. Next slide, please. So on this slide, we look at prevalence of hypertension a little closer and over time by race and ethnicity from 2016 to 2019. So as you look across, the dotted line again is the average, which is around 29% for hypertension. And those that are above the dotted line are three groups in particular. So you have African Americans, and then you have American Indians, Alaskan Natives, And then you also have Native American and Pacific Islanders. That line, as you see, looks like a V, so it's an anomaly there. That data is a little unstable because of the sample size. But then what you also see is a downward trend for African Americans and also American Indians, which is the direction that we want them to go. And for the other racial ethnic groups, those are below the line. So they're doing a little bit better than African Americans and American Indian Alaskan Natives. Next slide, please. So then when we also look at diabetes, approximately 3 million Californians are affected by diabetes. And the common forms that we typically look at are type 1 and type 2. When we think of type 1 diabetes, we typically think about it being diagnosed in childhood and, really being linked to obesity. But, it's a condition that can happen at any age. So it's, becoming higher on the radar within our branch. Next slide, please. So here we're also looking at the prevalence of diabetes by race and ethnicity from 2016 to 2019. And the average for diabetes is around 9.9%. And you see some of those same racial ethnic groups that are impacted by diabetes, like African Americans, Native Hawaiian, Pacific Islanders, Latin Americans or Latinos have made it above the line. And then also you have Asian Americans. Again, you see with Native American, Native Hawaiian, Pacific Islanders that the line is a little askew, and that's because those numbers are low and they're unstable. Next slide, please. So when you look at those diagnosed with cardiovascular disease and diabetes, approximately 1 in 4 adults diagnosed with heart disease, stroke, or high blood pressure also report being diagnosed with diabetes. And then 1 in 2.5 adults diagnosed with heart failure are associated with being diagnosed with diabetes. So I didn't get a chance to look at this like as an odds ratio to see about the likelihood of having heart disease and diabetes with the CHIS data, but I was able to look at the California Burfis data and look at high blood pressure and diabetes. And what the data showed me that when you look at the odds, you're almost 7.7 or 7.5 times more likely to report diabetes if you are diagnosed with hypertension. So that's pretty large. Next slide, please. So then we also look at diagnosis with cardiovascular disease and diabetes by race. We see some of those same racial ethnic populations impacted and or reporting cardiovascular disease and diabetes. So for heart disease and diabetes, you see American Indian, Alaskan Natives, Asians, and then you see Latinos. For heart failure and diabetes, you see African Americans, American Indian, Alaskan Natives, Asians, and Latinos. For stroke, it narrows down to Asians and Latinos. And then for hypertension, it stays in there with Asian Americans and Latino Americans. Next slide, please. So then we also look at the leading causes of death. When we typically talk about the leading causes of death, it's always around heart disease and stroke and diabetes and hypertension are among the top 10. But when we look across time from 2019 all the way to current number of death rates in California, what we see is a change in some of the trends. So heart disease was ranked number 1 in 2019, but then it dropped down to number 2 in 2020 and 2021. And we can all assume or figure out what crept into the number 1 space, and that was really COVID-related deaths. So it knocked heart disease right out and put them in second place. But if you take out that anomaly without a pandemic, then on average, heart disease remains the number 1 leading cause of death in California. Next slide, please. So when we think about what has California done well and what can we improve upon? So we really met our Healthy People 2020 heart disease and stroke number 2 objective, which was to reduce heart disease and deaths by no more than 102 age-adjusted deaths per 100,000 populations. So that means that we were lower than that. So we did really well in that area. So the work that you all are doing is fantastic. Continue to do that. Just start to focus more on those racial ethnic populations that are disproportionately affected by cardiovascular disease and diabetes. And then also when you look at the Healthy People 2020 heart disease and stroke indicator 3 objective, We didn't do so well with reducing stroke deaths to no more than 34.8 age-adjusted death rates per 100,000 population. Now, some counties were met this goal, but on average, California did not meet this goal. Next slide, please. So CVD and diabetes associated risk factors. So we know that the areas really impacting whether or not a person reports being diagnosed with cardiovascular disease and diabetes are typically around health behaviors and health choices. So when we look at obesity and overweight, the populations that are primarily reporting that they are obese or overweight are among African Americans, American Indian, Alaskan Natives, and then Latinos. And then for smoking, it's African Americans, again, American Indian, Alaskan Natives, and then also whites. For physical inactivity, we have African Americans and Native Hawaiian Pacific Islanders. And then for no access to fresh fruit, vegetables in their neighborhood, you have African Americans right on the line along with Asian Americans. And then you also have right above the line, American Indian and Alaskan Natives. Next slide, please. So with chronic conditions such as cardiovascular disease and diabetes, we know that there's a cost to our state, and there's an expensive cost to our state. So in about 2018, it was estimated that cardiovascular disease cost California an estimated $51.9 billion. And for diabetes, it was $18.9 billion. Now, this was about 4 years ago, so the numbers are even higher today. And these costs are specific to healthcare costs for healthcare utilization, healthcare services, and then loss of productivity and also loss of life years. Next slide, please. So to address, cardiovascular disease and diabetes disparities through programs, what we do here at the California Department of Public Health Chronic Disease Control Branch are activities through our Prevention Forward program, which is a 5-year grant that we were funded through CDC to address diabetes, prediabetes, hypertension, stroke, and high blood pressure and high blood cholesterol management and control. Next slide, please. And we're able to accomplish that through 3 objectives. And those overarching objectives are 1, to assess and increase the use of healthcare reporting systems to identify patients with chronic conditions and to ensure that they're able to report standard clinical quality measures. So that means that patients are receiving at the minimum the standard of care required for treating someone with diabetes or with hypertension. And because we know that different populations address health and health outcomes differently, sometimes different practices should be implemented so that those populations receive, in addition to additional care, to supplement that standard of care. And then for objective 2 is to identify policies and procedures within the organization to identify and prevent chronic conditions. And then the third objective is to assess use of team-based models to manage, monitor, and refer patients with chronic conditions to nationally recognized lifestyle programs. So really, how are we incorporating some of those non-physician team members, which was really imperative during COVID when patients were having or experiencing a delay in healthcare services because they were afraid to go to their healthcare provider for care. In those instances, you would have pharmacists or even community health workers, or even just, case managers who can go out and talk to the patients, or if they're going to their local pharmacist to pick up medication where they can get that health education on how to manage when there's a delay in care. Next slide, please. So for the first objective, some of the activities that Prevention Forward has looked at is really linking our partner clinics and hospitals to pharmacies and to their electronic health systems technology to assist in them ensuring that the patients are identified and diagnosed, and that they're using those systems to refer their patients to lifestyle change programs and to receive standard quality of care. So really, when you think about the electronic health system, it's like what alerts need to be turned on so that when a patient comes in and they are among those racial ethnic groups that are highly disparate by cardiovascular disease and diabetes and are also impacted by those associated risk factors, that they're referred to the right programs to promote and encourage lifestyle change. So really utilizing the EHR as a prompt to promote healthcare management. And then also Prevention Forward is promoting telehealth capacity to link patients to healthcare access to reduce delay in care. So what are some of those practices that health systems have put in place, especially during COVID, that is allowing them to link to patients that are technologically savvy so that they can continue and maintain routine care and management? Next slide, please. So then for objective 2, when we're talking about policies, Prevention Forward is promoting the patient care process, which includes comprehensive medication management and medication therapy management to manage CVD and diabetes. And in this instance, it's really connecting those non-physician partners like pharmacists into the care team so that they can encourage the patients to remain abreast and adhere to their medication for the management, and then also monitoring of their blood pressure and or diabetes or glucose levels so that they can report that back to their provider so that they can determine what is the best route and practice for that patient to manage their health when they leave the doctor's office. Prevention Forward is also promoting and hosting health education and self-management of CVD and diabetes webinars like this one through Right Care. They also hold Healthy Hearts and PD-STAT meetings so that information is shared around glucose monitoring, as well as, incorporating these non-physician team members and CHWs into the care team. And then Prevention Forward is also promoting adoption and implementation of team-based care approaches that I just mentioned to expand that care team to ensure that patients who are at risk are being touched at every point, and especially when you have a pandemic, and I can't express that enough because we all are going through it, when there may be a delay in seeking care. Next slide, please. Okay, so then in objective 3, with the promotion of team-based care, Prevention Forward is sharing information through the CMM, collaborative practice agreements, and adoption of team-based models. The staff is working to increase equity capacity with community health workers and providers to promote improved awareness and treatment for patients with cardiovascular disease and diabetes. The staff is also hosting webinars on lifestyle modification, referral topics regarding self-management of blood pressure monitoring and training. And then they're also encouraging organizations within target areas to increase their number of ADA, which is the lifestyle change programs that are accredited through the Centers for Disease Control and Prevention, to increase monitoring and control and management of diabetes within those areas that are highly prevalent with those conditions. Next slide, please. We're also using Prevention Forward for surveillance. So to monitor treatment and management and referral. So to really look at how are our partner clinics and hospitals doing in the areas of managing chronic conditions. Some of those health systems have programs in place, and by providing them with additional information, they're able to be more aware of those alerts that are needed to prompt management and practice and encourage the patients to really self-manage their health conditions when they aren't able to go into the doctors on a regular basis, or there is other underlying issues to why they may or may not seek care, but to take that opportunity to really manage their own health. And then so the next steps are to implement evidence-based interventions in our partner clinics and hospitals and pharmacies that monitor change in screening, where they're sharing the information across, each organization. If the pharmacist is able to educate the patient and they're linked to the provider's EHR, share those notes so that when they're adjusting the management plan, they have that information. The same way with if they're referred to a lifestyle change program, that information is somehow shared back to the provider so that they can curtail their management plan when they're talking to the patient. Next slide, please. So then we also have our cardiovascular disease prevention program, which is another Centers for Disease Control and Prevention block grant funding that the California Department of Public Health has, that we are interested in increasing hypertension control. Next slide, please. And through that program, we really host a lot of Healthy Hearts California meetings. We partner with universities, pharmacists, and health systems for stroke prevention and management through team-based approaches, including CMM. And then we also want to update the California Master Plan for Heart Disease and Stroke, which, we have a plan in place, and a lot of the indicators we have not met, but to really introduce some of the new interventions such as CMM and how that can really extend care outside of the healthcare walls and into the communities where the populations are most despaired by cardiovascular disease and diabetes to improve those health outcomes, especially for Californians. Next slide, please. All right, so that brings me to the end of my presentation. If you all have any questions or comments.
Thank you,
Oh, thank you,
Katrina.
Katrina. Go ahead, Hattie.
Ed, you're on.
All right, so help us monitor the chat. And again, thank you very much, Katrina. This is wonderful information. I'll just kick it off. Could you share with me, this is great hearing about the grant that you got. By looking at this data, I think a lot of the interventions you mentioned really is dealing with a whole population of patients with those conditions.
Mhm.
Could you share with us a little bit more about any insights or any specific interventions you're looking at or you'd like us to think about that directly looks at those patient segments that are disproportionately experiencing the higher rates of disease? And if you can share a little bit from your approach from where you said the CDPH, that could be insights for us. Thank you.
Okay, so specific interventions are really EHR optimization. So health
Okay.
systems, it would really behoove you to think about how to expand on turning on those alerts that don't cost you anything. So I know cost is a huge issue. So there are pieces or components within the EHR that you can turn on that addresses a lot of the social determinants of health that can be used to determine the healthcare plan. And you want to capture all this information. It's like, you have to think about, what is the best way to increase communication between the provider and the patient. If you turn on those alerts and you're asking questions about, their physical activity, asking about, well, what are you actually doing at home to, manage your hypertension or to manage your diabetes? Asking those questions prompts the patient to really assess what are they doing. And then it can give the provider an opportunity to promote that self-management at home. And then also thinking about ways to incorporate community health workers into the care team, because we know that there's a limited time that a provider can be in with a visit with the patient. And then there's like the nervousness for the patient, and then, just the time constraints. The CHW can really come in and be like that intercessor and the patient navigator and advocate for the patient to help them with the health education and even like navigating the patient portal. Because a lot of information is shared through there. If maybe the patient doesn't know how to do that, that's something that the CHW can help them with, as well as getting them referred to lifestyle change programs and incorporating some of those activities into their behaviors. And then also linking up with the pharmacist and figuring out a way to share data and information. So a lot of this is really hinging on the EHR and its ability to either alert and share information between, these different agencies so that the management plan can be adjusted, so that each patient is really tailored to improve their health. So I would say those are a few of them.
All right, thank you for that. Let's open the floor to other folks. And Hattie, sorry I interrupted you. I thought you were going to make some comments.
Well, Katrina has been just a wonderful point of light in the whole effort over these last few years in the capital region to use data to understand the situation and to try to leverage change. So for instance, she worked with us on a data project looking at where do we have the worst rates of heart attacks in the state? And it turns out that the zip code that the Capitol building sits in and the California Department of Public Health is one of the worst in the state. It's a hot spot that we don't quite understand. And we were just about to launch a project with Dr. Sky and the Sierra Health Foundation to try to address creating a more positive environment in the community through a blue zones approach to try to tackle that right before the pandemic. So we've been very fortunate to have other mechanisms that we can deploy. And it's been a great time of innovation during the pandemic to be able to connect with patients by video. A lot of them really prefer it. So we've all been talking about telemedicine all these years and how great it would be if patients could see their providers. We know that from our data, working together over these many years, provider groups that are open nights and weekends have better outcomes for their patients, because of course, those of us who work don't want to take time off to go to the doctor during our workday. So telemedicine has sort of been a nice innovation to address that ready access to providers. And Katrina is bravely leading the charge within this very complicated state of California to help keep some of those innovations growing and thriving.
Good. So we got some questions coming in. So let me go to one that's on the chat, and I'll go to Oliver Brooks next. So there's a data question here, speaking about geography. And the question comes from Paul. He asks about the smoking rate seems to be lower in California than the rest of the United States. And the question is this a reflection of active intervention by groups like Right Care or other public health efforts, or this is something just unique to the geography and the culture of California? What are your insights?
Okay, well, excellent question. So I spent in my postdoc, I focused on state policy around tobacco. My dissertation was around chronic disease and smoke-free policies at the state level. So it absolutely has a lot to do with interventions. Passing policies impacts smoking outcomes. But it's like, you have to honestly think about, like, when you think about the racial ethnic disparities, I would be remiss if I didn't say, with African Americans in particular, they have the lowest smoking rate for individuals younger than 18. Once they turn 18 to 24, the smoking rate is exponentially high. So you have to ask, what happens between that age group to get that population to start smoking? Of course, it has, some of it's behavioral, a lot of it is environmental stressors. That population is also highly disparate by cardiovascular disease and diabetes. So then when you think about those health outcomes, it will benefit in a state where you have those populations disparate to have policies and interventions in place that reduce that type of behavior that's going to have a worse health outcomes on people who are already, I won't say predisposed, but are anticipated will have chronic conditions. So interventions like tobacco policies are necessary. Smoke-free policies are necessary. So if they're not exposed, because then that too has an impact on health outcomes, and especially for those with chronic conditions. So, having, those alerts on the EHR that ask about smoking, the constant asking or promoting of smoking cessation is necessary. The linkage to, lifestyle change programs that also talk about smoking cessation are all needed. So the interventions play a huge role.
Thank you very much. I'll go to Oliver next, and after that, Chhavi.
All right. Thank you very much, Edward. An excellent presentation, Katrina. Two things. One, that first question that came through, I'm glad you answered that, because I had seen that African Americans had lower rates of smoking, but I guess it's what quote unquote teen smoking. So that's really compelling to think about. It went from lowest to highest, and something's going on there. My question though is how health literacy relates to the disparities. And I want to clarify something that what I call health literacy, the definition is not how literate you are, but how you process health information. So I may say something to a patient that's African American, and they interpret it totally differently than maybe another population. So I guess I also want to see that you concur with that definition, because I think people think it's your reading level or your level of education or engagement.
Wonderful, wonderful question. So earlier in my career, I did a lot of asthma disparities, and a portion of that was looking at health communication and health literacy. And how we approached that was really, how do patients understand and are able to communicate their asthma outcomes to their provider? And how do they actually understand what the provider is saying? And do the provider understand them when they're talking about asthma? So literacy really needs to be understood from not just a reading capability, but also a communication and an understanding. So, surveys such as Burfus will ask questions like, do you feel understood by your healthcare provider? Those questions are really important because some people don't like to admit that they don't know what their health provider is actually saying when they leave the office. So then when they go home, they don't really know how to manage their healthcare. All they heard was change this negative behavior, or you're African American, or you're Latino. It's an expectation that you're going to have this condition. And so they only hear the negative side of that, and not necessarily that, you don't have to suffer or be despaired or have the worst health outcomes from being diagnosed with a condition, that it can be reversed if you make some lifestyle change choices. So definitely it has a lot to do with understanding and communication. So excellent question.
Thank you. Next question goes Chhavi Mehta.
Thank you, Ed. So Katrina, my question to you was that have your group considered having South Asians as a separate ethnic group because of the very high risk of diabetes and heart disease, and not having the traditional risk factors like obesity, because the interventions might be so different for that group? Thank you.
Wonderful question. I will say that looking at the Asian population is a priority. However, we have not really had a conversation on how to address it. So far, it's been more of a general address if the group is in a high prevalent population, which was defined by various factors, such as if you have a chronic condition, if it's English as the primary language spoken in the home, and then also like physical activity and all of those factors. But definitely we have to think about that, because then it gets at a standard is not standard across the board. And you have to think about the populations that you're serving and what that means for that group. Because as you just indicated, Asians are not typically on the scale for obesity. However, they have a high level of diabetes. So then what is actually going on there? What do we actually, need to do? Should we partner with, some of our sister programs like NEOP, which is like the nutrition education program, and think about, like nutrition efforts in those communities that are highly prevalent with South Asians, so that we can address diabetes like in a backdoor effort. So I definitely think that's something that we can talk about within our branch, and then also think about what does standard mean across all of the racial ethnic groups that are impacted. So great question.
Thank you.
All right.
I just want to say that, Chhavi, since we last saw you, we did have a program on the excess risk among South Asians last April, led by Nirali Vora and Dr. Susan Ivey. We do have on our website and have delivered to the California Department of Public Health a brief on that critical issue of early excess risk among the South Asian population. So we would love to work with you on that. And with that, Ed, back to you.
All right, Carol, thank you for your patience. Next question for you.
Thanks, Katrina. Great presentation. You mentioned turning on the electronic health record and the alerts, and you may have good capture of race, ethnicity, language data, but if you look at the data from academic health medical centers, it's only captured about 50% of the time at best. So how do you think, any ideas from your experience about how we promote much better collection of this data when we have patient encounters?
Really, so this one is a harder question.
Sorry.
It has to be more of the buy-in from the medical directors. They have to see the return on investment. So like if you take, for instance, a person who presents at the emergency room with a stroke, the idea is that you don't want them to come back with a recurring stroke, because it costs you more money if they come back. So then I would say a good practice would be to ensure that you collect all the information that you can at that follow-up visit. And if it's not in the alerts, you can show that there's a cost benefit to collecting this additional information, particularly among that population, because it can reduce rehospitalization. So if you can associate a cost with the change in behavior at the health systems level, that's how you get those alerts to work. That's how you really get the doctors to not have alert. You don't want them to get alert fatigue either, but just to know that, you know what, I need to know this information because this group is at particular risk. The standard will not work for this group. And it's not in a sense to target, but it's in a sense to really improve health outcomes, because the standard isn't getting us to that health outcome, and COVID just blew that out the water and showed everyone.
I love that. You frame it as the same kind of quality of data as getting a blood pressure. It's as impactful. I love that.
Right.
Yeah, thank you.
You're welcome.
Yeah, and then I think we'll have our last question for this session to come from Dr. Keith Evans. You have the floor, sir. If we don't hear you, Dr. Evans, I wonder if you're double muted.
Oh, Keith, are you able to unmute yourself and bring your video on and ask your question? We see you have your hand raised. There's Dr. Emmons.
You're still muted, sir.
Are you muted on your phone? Oh, we cannot hear you at all. So while he's getting his audio, I'll just say that Keith Emmons leads our heart failure work group and has been a dedicated right care leader for many years now from Los Angeles. Okay, so we have your mute button on. Now it's unmuted. Let's try again. Do you want to type it?
It may be hard to type because if he's in a car, I bet it's a small screen.
Keith, I think what we should probably do is have you test that a little bit with Jenny while Dr. Mehta is presenting, and then we can have you ask that question once you get your audio worked out later in the program.
Well, thank you. Again, thank you all for your patience as we navigate technology. Again, Katrina, thank you for that talk, and thank you for standing by. I think we're going to have other questions. And once again, I really appreciate the work you're leading at the California Department of Public Health and bringing to light the work and helping us close these disparities. Now, the next section of our agenda gives me great pleasure to introduce my dear colleague, Dr. Chhavi Mehta. She is an internal medicine physician with Palo Alto Medical Foundation, actually is my colleague on my team in quality as well. She wears many, many leadership hats, too many to mention here, but the one I really want to call out here is that she has always been a passionate leader in guiding and managing and improving outcomes in chronic disease. She has been our system-wide leader overseeing diabetes improvement in ambulatory care. And she actually now is leading our intervention efforts and our chronic disease efforts in our quality program as well. Actually, prior to this, I thought I know her well, but I had no idea that she actually has OBGYN residency training. That was something new that I did not know, although she is now practicing as a board-certified internist as well. So without further ado, I'm going to give the floor to you, and I'll be on standby to help answer any questions on this section as well. So Chhavi, thank you again for coming, and the floor is yours.
Thank you, Ed. Thank you so much for that introduction. So my topic today is that I'm going to talk about our efforts on cardiovascular risk reduction in patients with type 2 diabetes here at Palo Alto Medical Foundation. Next slide, please. So we heard from Katrina during her presentation, the burden of cardiovascular disease among patients with diabetes. So cardiovascular disease or type 2 diabetes is associated with adverse cardiovascular events. These include not only coronary artery disease, but also cerebrovascular disease, peripheral arterial disease, and also heart failure. Heart failure is actually the second most common presentation of heart disease amongst patients with diabetes. And if we look at the numbers for a patient who hasn't had an MI, if they have diabetes, then their risk of kind of getting an MI is about 20% as opposed to, let's say, 3.5% for a patient who would have diabetes. So that kind of signifies the cardiovascular disease burden for a patient with diabetes. Now, in the past, we have focused on our diabetes control metrics like A1C control, blood pressure, statin prescription, whether patients have had nephropathy screening or not, and kind of as separate entities. And we hadn't thought about kind of approaching this from more of a cardiovascular risk reduction in diabetes. And that's what we changed this year and last year. I think we started beginning of last year or even before that, when the ADA guidelines recommended the use of newer therapeutic agents to reduce cardiovascular risk among patients with diabetes. These were the SGLT2 inhibitors and the GLP-1 receptor agonists. And the recommendation was to use them regardless of their baseline A1C. So that's where we thought about looking at our diabetes population as a whole and thinking about cardiovascular risk reduction for them. Next slide, please. So if we look at the vascular complications of diabetes, we can kind of categorize them into two broad subsections, macrovascular and microvascular. So macrovascular are our coronary artery disease, heart failure, peripheral arterial disease, and stroke. And microvascular is neuropathy, nephropathy, retinopathy. And we know that glycemic control has positive impact on the microvascular complications only. Large randomized controlled trials like ACCORD and ADVANCED gave us enough evidence to say that if you have patients who we are tightly controlling their blood glucose levels or A1C levels, we don't see a lot of benefit in terms of cardiovascular disease-related mortality or overall mortality, but we see more side effects like hypoglycemia. But tight glycemic control does improve the microvascular outcomes for a patient with diabetes. So our efforts are focused on macrovascular outcomes, which we want to kind of impact. So next slide, please. So if you look at the American Diabetes Association guidelines, these are the risk factors that they list. These are the cardiovascular risk factors for a patient with diabetes, which includes high blood pressure, dyslipidemia, a smoking history, family history of premature coronary artery disease, chronic kidney disease, and presence of microalbuminuria. And I added prescription for GLP-1 receptor agonist and SGLT2 inhibitors in appropriate patient as another risk factor. So the recommendations are to assess them annually. So for our work that we are doing at PAMF, I mean, we do focus on all the measures like chronic kidney disease, whether the patient has had nephropathy screening or not, whether they are on ACE or not. But as far as the cardiovascular disease is concerned, if you can just, so we focused on hypertension, dyslipidemia, and prescriptions of GLP-1 receptor agonist and SGLT2 inhibitors. So these were the three broad areas of work that we focused on each individual patients, like what was their blood pressure, whether they are on a statin or not, and if appropriate, are they on a prescription of GLP-1 receptor agonist or SGLT2 inhibitors or not. So next slide, please. So before I do a deep dive into our actual workflows and what we did, I just wanted to kind of emphasize on the key principles of population health that we sort of made sure that we take into account when we are designing our workflows. First is patient engagement. We want to make sure that our patients are engaged. And I know we did talk about health literacy just a moment ago, that health literacy doesn't mean it actually means that it doesn't matter how well educated a patient is, but do they understand what you are trying to tell them about a prescription, and do you understand what they are trying to tell you? So we know that if patients are engaged, that leads to better quality outcomes and lower cost of care. And at the same time, we want to make sure that our patients are activated, meaning that they have the necessary knowledge and skills and the willingness to participate in their own care. And I think that is the key thing to get better quality outcomes. And then we wanted to make sure that we have good clinician and staff engagement, because whatever workflows or we choose, or whatever benchmarks we propose, we wanted to make sure that it is meaningful to our clinicians, that they actually can connect with those. And we wanted to make sure that our workflows are such that they are easy for our staff to follow and for our clinicians to follow. Kind of like the BPA fatigue, because if we have alerts, EMR alerts for a number of things, then soon people start ignoring them. Then the third key factor that we took into account was looking at the population as a whole. So we want to look at the population as a whole, but at the same time also sort of look at how we segment our population, because I mean, we do have the diabetes population as a whole at PAMF, but then there are certain criteria which may make the needs of one population different from the other. So whether we segment the population based on race and ethnicity, or we segment them based on their risk, like their blood pressure control levels, whether they have come and had an office visit or not. So these were some of the other key criteria that we considered. And then transparent data and reports. I think transparent data, having access to that and making sure that it's provided to everybody in the organization is a key fundamental tool. And that can actually help focus attention to a key quality measure. And then you can work and then you can build a culture around it, a culture of improvement. So we do have reporting structure, and we do provide transparent data to all our clinicians and staff members. And that can drive actually best practices and spread of best practices, and that can drive to continuous improvement, which is the last pillar of population health. So these were some of the key principles that we have in mind when we are designing our workflows. So next slide. So I'm going to start with controlling high blood pressure or hypertension control or hypertension in patients with diabetes. I mean, I have to say that if we look at the key pillars of for population health, the key things that we focused on for blood pressure was clinician and staff engagement and the population segmentation approaches and our outreach approaches. We did have patient engagement as a strategy, but I think that for whatever reason, if a patient has high blood pressure, then it's easier to engage them than, let's say, a patient who's not on a statin, or a patient who have had consistently elevated blood pressures. So the blood pressure targets of less than 140/90 for the population, as I said, we are kind of like looking at the population as a whole. So we had to choose one sort of a benchmark that we would hold everybody accountable for. This blood pressure target is based on ADA recommendations. And if we look at the Accord and Sprint trials, that majority of the patients with diabetes, if they have their blood pressure less than 140/90, then there are positive cardiovascular outcomes. And then we also want the clinicians to use their judgment on which particular patient they're seeing and what their blood pressure goals would be. Next slide, please. So if we look at the data, then hypertension has the strongest evidence for causation of cardiovascular disease as far as the causation is concerned. Improvement of blood pressure in a population can save more lives than a lot of other clinical interventions. So if you look at this data, it shows the log transformed and untransformed absolute risk of developing cardiovascular, coronary artery disease, or stroke. As a function of systolic and diastolic blood pressure, and it's stratified by age. So you can see that as the systolic blood pressure increases and diastolic blood pressure increases, your risk of coronary artery disease and strokes increase. And the older you are, the greater the risk. So, I mean, we absolutely vital that we have the blood pressure controls of our population under a certain recommended targets. Next slide. So what are the interventions for our blood pressure? So I'm going to kind of just spend a few minutes on this slide, because this is kind of the key things that what we are doing. So what in the last 2 years, the one sort of like, if I had to choose the one intervention that has sort of given us really good results are our second BP check. So and this was based on the data that showed us that when a patient comes to the office and has a blood pressure checked, and if that initial blood pressure is high, and if you give the patients 1 or 2 minutes and you recheck it again, 30% of the time you get a normal blood pressure. So we had this big campaign across BAMF, which led to a policy change where second BP check by medical assistants became a policy. Medical assistants don't need to ask the physicians on whether they should recheck the blood pressure or not. If the initial blood pressure is greater than 140/90, they check the blood pressure again. And also we had a big campaign on training the staff and doing quality checks on them on a regular basis on using the automated BP cuffs. So when the patient comes in, how the MAs are going to check blood pressure, they have to sit the patient's feet are touching the ground, their feet are not crossed, their arm is at the heart level, and then we use automated cuffs for checking the blood pressure. And once that is done, if the second blood pressure is also high, then the medical assistants leave a visual cue. So for my clinic, for example, they'll stick a laminated heart on the door of the clinic, of the exam room, to alert me that this patient does have high blood pressure. And then, make sure that after the patient leaves, there's a follow-up appointment that the patient has scheduled. Next. So this is what we are doing at the staff level. Then when the patient is seeing the physician, we do have that visual cue will kind of remind the physician that that something needs to be done, blood pressure is high. And then we want to encourage patients to schedule follow-up appointments. We do have this physician level data on blood pressure control that we distribute to physicians. We have something called a scorecard, which lists all the quality metrics at the physician level and how that physician is doing. And we do encourage, we do have Sutter standard guidelines for hypertension, which are revised periodically, and the physicians are encouraged to follow those guidelines. Wherever possible, we do focus on team-based approach, where we have our nurse practitioner colleagues or physician assistant colleagues kind of help with blood pressure checks, or our RNs help with blood pressure checks. So if you click on the next button. So with COVID, we saw the telehealth come into place. So we had video visits that were suddenly we were doing video visits and telephone visits. So we noticed that in 2020, our blood pressure capture rates dropped quite a bit. And part of it was obviously deferral of care by the patients, but also video visits. So we had to kind of think about how do we develop workflows to capture blood pressures during virtual visits. So we have two ways of doing that. One is that if a patient has a video visit scheduled, then instructions are sent to them to keep a blood pressure reading ready for the medical assistants at the time of the rooming process. And we also kind of standard material on how they can check blood pressures at home, how they can use a machine, which machine to buy, not buy an arm cuff, not a wrist cuff. So all that information is sent to the patient, and then the MAs can capture that blood pressure reading at the time of the virtual visit and put it into the Epic into the EMR at the appropriate place. And if the patient has not taken the blood pressure, then we encourage them to send us My Health Online messages with the blood pressure readings. Now, our biggest barrier right now is that lack of, or patients don't have access to blood pressure machines. A lot of patients don't have blood pressure machines, and they just simply don't use them. They've always relied on physician offices or their doctor's offices to get their blood pressure checked. So we are working on that. We are also kind of collaborating with our community health resources, our community health RNs, to educate patients on blood pressure and kind of teach them how to use the machine. So blood pressure machine at home. So that's work in progress. And if you click one more, so this is the data approach. So if you see here that the workflow is that we start with the patient showing up at the time of the showing up for the appointment. The MAs have a specific workflow for capturing the blood pressure, rechecking it if the first one is high, setting up a visual cue for the clinician. The clinician comes in, they look at that visual cue, they address the blood pressure, and then we want to encourage patients to schedule follow-up before they leave. And that follow-up could be as soon as 4 weeks before, if a medication change has been made. But not all of our patients schedule follow-up appointments. So those are the patients that are captured by our data team. So we do follow a patient segmentation approach for our patients with hypertension, because as we said, we cannot, one is that it gives us a chance to utilize the resources that we have and kind of capture the patients who are highest risk first. So the patient segmentation approach that we use is first the patients who are not seen in the past year. These are the patients who have absolutely not come in. Then we have the second category of patients who have persistently elevated blood pressures, that they have 2 elevated blood pressures, and they have had no medication change made in their last visit. And we have cutoffs for blood pressures in that category as well, so that we are able to capture absolutely the high risk patients who did not have medication changes made during their office visits. And if the patient has access to home blood pressure readings, we absolutely want to utilize the video visits and leverage those. And then we have this one medium risk category, which I think is kind of cut off from here, is the patients who saw the physician, they had one single elevated blood pressure and they did not have a follow-up appointment. So, we have these patients who are like low risk, medium risk, high risk category, and we can leverage our outreach based on the resources we have and what kind of patients do we want to outreach. We did have access to pharmacists, but not recently. So we haven't been able to kind of collaborate with our pharmacist colleagues for management of blood pressure. So that's again something that is ongoing work. So these are our interventions for blood pressure. Next slide, please. So as I said, transparent data as an engagement tool. So this is an example of our second blood pressure report. So this is across all clinics. This is kind of, the report goes to the level of individual clinics, and we see here that, and we have set goals that, okay, 85% is the goal, that if a patient comes into the clinic, if they have an initial blood pressure which was greater than 140/90, then 85% of the time, a second blood pressure should be checked. And that this gives us a chance to look across all the clinics, see where the best practices are, and see what the barriers are for the clinics that are not performing so well. Next slide. And this is our overall sort of, example of the report that we have. This is for overall PAM for our various diabetes metrics. The black line is blood pressure. As you see, in 2020, we saw a drop, and we know that COVID and deferred care was one cause. Video visits was another cause while we were trying to develop our workflows. And then, we're seeing a uptick in 2021, and we hope to kind of continue that. So these metrics or these reports are available to anybody to look at, to our clinic managers, to our individual physicians. And our team does send these process metric reports to the office managers on a regular cadence, so that it stays on their radar on how their staff is performing. And we have had interest from physicians wanting their individual quality scorecard as well. So next slide. So coming to statins, I think for statins, patient engagement is the key thing. For whatever reason, statins, there's a lot of controversy, a lot of misinformation about side effects and all. So patient engagement is our key strategy for statins. So our outreach for statins, we start with a letter to the patients as the first step, and then have our medical assistants outreach those patients so that the patient is already primed that, okay, yes, somebody's going to call me and they're not caught off by surprise. We have developed a lot of scripting for our medical assistants so that they can, which can help them answer the questions that the patients might have. And those scripts were developed with a lot of our patient advisors and a lot of other people who have done the work around it. And if the patient does really have side effects, then we don't approach them. And then as the third step, we ask our primary care physicians and our cardiologists to kind of, look at the patients who are not on statins and really have that one-on-one conversation with them to see what the barriers would be. Next slide, please. So this is sort of the statin hesitancy. I think this is somehow, for whatever reason, as I said, statins is one of those medications which there's a lot of controversy around them. There's a lot of misinformation on the internet about the side effects. Actually, a study in UK which was done was found that because of the misinformation by media and the internet, they see that not only are patients hesitant to take the statins, but also the clinicians are hesitant to prescribe them. So there's this difficulty with the statin prescriptions. I mean, these all questions would seem very familiar to you. My muscles would hurt. Will I get diabetes? Will I get dementia? Will my liver fail if I start statins? Will I get a stroke if I start statins? So it's kind of important to address these issues. We felt, and kind of have some answers for our patients that will help clarify this misinformation for them. So next slide. So what we have done for that is that we actually talk to our clinicians and ask them that, okay, what was the key thing that you feel is a barrier when you're prescribing statins? And we have seen that there is a difference in this statin hesitancy across our different regions. So we developed a fact sheet for clinicians, which provides actual numbers to the patients that, hey, the cardiovascular risk reduction is about 35 to 40% for you. So if you're, use the Mayo Clinic tool or ASCVD risk score tool and kind of show them on the computer what their risk is, and then say that you will have 35 to 45% risk reduction, but the diabetes risk is only 10 to 20 patients for 10,000 treated patients, or the stroke risk is, the myalgia risk is this number. So actually provide them with actual numbers, which sort of carries more emphasis and more, it's probably sort of more convincing to the patient that the risk of cardiovascular disease is, the relative risk reduction is way higher than the side effects, and kind of promote a shared decision making. That is the key thing. And then we want to shift conversation from, okay, this is yet another prescription to bring your cholesterol down, to that this is something which will help in reduction of heart attacks and strokes. So primary prevention, this is going to prevent you from having another heart attack. And then another thing is adherence. Statin adherence is also a key thing which we haven't addressed actually looking at the data yet, as of yet, though we do have data on, we can extract data on statin adherence based on their prescription refills. But we wanted the clinicians to emphasize this as a part of their shared decision-making, that you ask the patients that, did you take the medication or not? And then, if a patient is coming in for a statin prescription, then we put this on the appointment reminder for the clinician to kind of actually get an alert that, okay, the patient is coming in for a statin discussion, and to be aware of, to be prepared for that. And then we encouraged leveraging video visit appointments for discussing statins, because again, this is, like video visits are easy. The patient doesn't have to kind of drive and come to the clinic, and they would be more willing to engage and talk to us. So kind of like, promoting everything we can towards a shared decision making. Next slide. So this is our data for our statin prescription. We participated in the AMGA bundle measure. And this was the time from where we did our interventions on creating like scripts for medical assistants, materials for patients, this active patient engagement strategy. We did see a 7.3% relative and 4.8% absolute increase in our statin prescription rates to 70.8%. And I think now this year it is about 75% of our patients are on statin. 75% of our patients on diabetes. Next slide. So this is the third sort of like intervention that we have. This is based on the recommendations or guidelines by American Diabetes Association on that patients with heart failure and CKD, regardless of their baseline A1C, should be on GLP-1 receptor agonist and SGLT2 inhibitors for cardiovascular risk reduction. The data was really strong on that. So next slide. So the evidence for all this comes from these 5 key trials: LEADER, EMPA-REG, CANVAS, REWIND, and SUSTAIN-6. There's 12 to 26% reduction in cardiovascular risk reduction, and there is significant reduction in 3-point MACE in patients with diabetes and ASCVD, reduction in heart failure admission rates, and the effect is in addition to aspirin and statin, and it is independent of hemoglobin A1C. And the 5 agents that are sort of FDA approved for this are AMPA and canagliflozin, liraglutide, dulaglutide, and semaglutide. So this was the basis of our intervention that we did. Next slide. So for this particular work that we did not have any benchmarks. There are no national benchmarks to say that, okay, if you have a patient population of 100, then, 50 of, and if there are like 20 patients with MI, then, what is the benchmark of how many of your patients should be on these medications? So we use this as the first step, as kind of like, an educational opportunity and to raise awareness about these medications. So we partnered with our endocrinologists to deliver didactics across all primary care clinics on the data behind these medications, how to prescribe these medications, what are the doses, what are the side effects, what do you have to watch for, what are the follow-up labs that you have to do. So that is the information which is kind of key, pertinent to primary care physicians, that what they would need in order to prescribe these medications. And that actually kind of got that discussion going. We have physician level prescription data, and which we validated and verified. And we are in the process of making patient lists currently available to primary care physicians, because this is something which we don't want to do direct outreach on, but we want the primary care physicians to kind of look at their lists and see who are the patients who they would think would be appropriate for this, whether they would like to see them, whether referral to endocrinology. We have EHR tools, Diabetes Smart Set, which makes prescribing these medications really easy. And as I said, there's no benchmark. So we are also considering having a VR approach or a variation reduction approach to this, where we can see where if we look at, like, if there are 20 physicians in a group, then what are the rates for each physician, and making sure that there's not a lot of variation in practice, and or setting up some internal benchmarks. So we are in the process of doing that. But we the endocrinology of didactics went very well. It was really well received, and it has sort of kind of we decided that we should have one every year for our primary care colleagues to kind of deliver whatever is new in the field of diabetes. So next slide. So this is sort of the data that we have right now for patients with ASCVD on GLP-1 RA or SGLT2. We are working on actually getting more deep dive into this, kind of getting the data by each division of PAMF and eventually to at the physician level. And we are sort of monitoring the percentage of patients who are on these medications by month to see if we see an improvement. So that's where we are at right now on this one. So I think this is my last slide. This is what I have. And if there are any questions, I'd be happy to answer them. Ed, I think you're on mute. I cannot hear you.
Oh, sorry. Again, thank you, Chhavi. I hope you all can see how lucky we are at PAMP to have a leader like Chhavi to lead our effort in this space. So on behalf of our group, thank you very much. We have quite a few questions already piped in. I'm going to go with the one that's typed. Then we're going to go to the ones that are raised hands. So the first question has to do with blood pressure cuffs. There's a couple of questions, and one, I'll put them all together. Do you have any incentives for patients with diabetes to purchase the right blood pressure cuffs if they don't have a previous diagnosis of hypertension? And linked with that, do you keep track of data of what % of our patients are able to buy their own blood pressure devices for home monitoring or telemedicine?
Yeah, that's actually a very good question. We don't have incentives for patients to buy to get a blood pressure cuff. We used to have our community resource nurses could, patients could come in and kind of borrow a blood pressure cuff to take home. But because of COVID, I think that stopped. So I think that's a great point. Our team has thought about it on how can we encourage patients to kind of socialize this idea of checking blood pressures at home. So this is something that we can think about as we discuss in our teams.
Can I add to her response? This is Catrina.
Oh, sure. Go ahead, Catrina.
Okay, so then another part would be like the health insurance plans. So like for the older patients, if they're on Medi-Cal, most likely they will cover a blood pressure cuff as well as like a glucose monitor. But then what will be helpful is that when they see the patient, to help to calibrate their blood pressure cuff. So when they go in, they can know either how off, how much higher, how much lower they are to what they normally see in the office. So if they're doing the blood pressure monitoring, they're not under the perception that it's a good monitoring when it's higher than what they would see in the office. So like the first part is the healthcare plan. And then the second part is the calibration.
So in Medi-Cal, definitely, I mean, like in my personal experience, I've tried to put in scripts for blood pressure cuffs, but they are covered and they are not covered sometimes. So we can look into that as well, but calibration is a really good point because we do that. We encourage patients to bring their blood pressure cuffs to the office so that we can kind of like, check their blood pressure reading against our instruments, which are calibrated, and help them calibrate their instruments if needed.
Yeah, thank you. The next question comes from our statewide chair, Dr. Bill Baumer, who's on screen right now as well. And he has a question about using coronary calcium score and could that be used and how have we used that to improve statin acceptance?
Yes, so we don't have that. I mean, like we definitely, in my personal practice, I have used coronary calcium score, especially for patients who are at intermediate risk and whose LDL levels are not telling me right kind of, straight that you should be on a statin or if they have a hesitancy. But, and we have used the coronary calcium score for our physician education but we don't have that directly integrated into our workflow.
I want to go to the raised hands, folks, and Stephen Sidney, you've been patiently waiting. The floor is yours. You're on mute on yours. Looks like you're double muted.
No, Steve. Let's just say that Steve is the head of Northern California research for Kaiser. Thanks.
Not exactly. I'm head of the research clinic, but I'm not the head of research. But thank you for the promotion there. In any case, I realize most of your presentation was focused on medical interventions. but I was surprised in the list that was presented at the beginning, which I think was the Diabetes Association, not to see anything about physical inactivity as a risk factor, or basically physical activity as a useful intervention. And I just wonder how you deal with that in your practices there, or how you message about that.
That's true. I mean, I was surprised too. That list of risk factors is from the 2021 American Diabetes Association guidelines. So physical inactivity is sort of, you know, we can refer our patients to nutritionists for weight loss. We don't have any specific programs at PAMP for physical activity, like we don't have exercise specialists or exercise therapists on site, but we do encourage, the physicians do encourage patients to kind of do whatever activity they can, which they can do consistently on a regular basis. But unfortunately, we don't have any programs embedded in our clinics.
Well, I wasn't even thinking of necessarily having specific programs, and encouraging them is fine, but you could give them something specific, like go out and walk a half an hour a day, which is a pretty, general recommendation for health. It's simple to give, and for the majority of people, it's something that they can do, and it's not complicated. It doesn't require special equipment. So I would, I just throw that out there. It seems like something that a specific message could be helpful with.
I agree. I think that's a really good point. A specific message on, just an exercise script, 150 minutes per week.
Mm-hmm.
That's sort of the recommended exercise level, right, which could be included in the physician workflow.
We have had Kaiser present in the past that is part of your electronic medical record. Is that right, Steve? I know that.
Well, there's two questions that basically get included in every visit that go into the electronic record, which are basically about, do you exercise, and how many days a week. I don't have on the top of my head, but it's as simple as that. How frequently do you exercise? How long do you exercise?
Okay, great. Next question, Dr. Bill Baumer.
Yeah, can you hear me?
Yes, we can.
So Chhavi, thank you very much for a very comprehensive approach to this. I noticed on your slide, and I thought it was a very good technique to look at prescription frequency for guideline medicines. And I thought that was a very good way to really check and see how it's done. Your GLP-1 and SGLT2 frequency was approximately 15 to 25% in that. And yes, there are no national guidelines or numbers on that to match. What do you think? What is your goal, do you think, for your healthcare system to achieve, and what direction do you want to get to that?
So truly speaking, I think that the key thing would be to link this to actual rates of reduction in cardiovascular risk. So if we can see that we had this many events when we started our project, of whether we say a MI or a stroke or peripheral arterial disease, and then we compare it, let's say, across time, and say that because of, and kind of link the prescriptions, that because the patients were on these medications, we saw actual reduction in the events. I think that would be the ultimate goal. But at this time, we are actually looking at, our goal is to see month-to-month improvement in the rates of these prescriptions.
So our goals for a lot of things like blood pressure control, diabetes, A1C control, and cholesterol control, or at least statin is in the 80 to 85% target that we're looking at across the state for right care. Do you think those targets should be at that level?
I don't think so, because the reason I say that is because of the fact that that yes, there is the guidelines say that GLP-1 receptors and SGLT2 should be prescribed to every patient who has pre-existing ASCVD, but then that regardless of baseline A1C, that's not something which is being done in clinical practice as of now. I see a lot of hesitancy among even endocrinologists and primary care physicians. Let's say if a patient is stable on metformin, their A1C is 6.5, then they would hesitate to switch them to an injectable medication or a SGLT2 inhibitors. Now, and the other thing is the cost of these medications, which I have to say is improving. Insurance coverages are improving. So I don't know if we can set the goals to 85% or 90% that high, but what should be the goals? I don't know yet.
There's a comment in the chat in Nirali. I see you here. I thought give you a chance to make your comments live if you wish to. But I will also like that while we work on that, I'd like to make a comment about Chhavi's about setting the goal. Actually, that has been a discussion we were talking about. And I think that is one area where hopefully the measurement industry can help us as we all collectively collect that, then we'll know and we will practice what is the starting point and where the benchmarks are. But again, just want to echo with Chhavi, what we're starting with is those diabetic patients who have suboptimal A1Cs, who have CVDs. That's a very clear target patient segment of which this makes absolute sense to go. And we're going to start there, measure our numbers, and see where we go with that. Like anything else in quality improvement, we won't let perfection get in the way, step at a time.
And I think it'll our initial data will tell us which direction to go in, and we can and we'll know more once we have a few months into it.
Riley, how are you?
I'm fine. I just got out of a busy clinic where my diabetic patients were not on statins. So you just explained that. Thank you, Chhavi. I apologize for missing, the beginning of the presentation. And I did wonder about that. I mean, I thought there it is in plain as print. Plain as can be, covered in the guidelines. What are the contributors to hesitancy? That's one question I had. And my comment was earlier when someone was asking about how do we get patients cuffs to do the comorbid risk factor management? And just a comment about the increase in these virtual health clinics that do remote patient monitoring. They have modeled their whole business plans after being able to do things like continuous blood pressure monitoring. And as part of that package, sometimes this particular company, which I'm involved in, so I'm a little conflicted, but I think there are others as well that have partnered with people who will provide the cuff. So this particular one has partnered with the Omeda blood pressure cuff company and provide it to their patients, and they're able to get it 80% covered by Medicare, Medi-Cal, and then most of these patients have some kind of 20% co-insure, the secondary insurance. So I am hopeful that technology is actually driving forward, improving access to those that have insurance. But I completely agree that there are many where something as simple as a blood pressure cuff and access to it could change their outcomes, but we need to do a better job. That should be sort of standard. But yeah, going back, Chhavi, I still don't have a clear understanding of why there's hesitancy among providers to start statins when the data is clear, isn't it? in diabetics.
I mean, across PAMP, we don't have that, we don't have physicians who are hesitant to prescribe statins. We've done several chart reviews on patients who are not on statins, and the key thing we found was patient hesitancy to be started on statins because of the fear of various side effects. As I said, I mean, I hear dementia, I hear a fear of diabetes, stroke, liver failure. And I did do some sort of literature research on it, and there is a lot of misinformation about statins on the media and on the internet for whatever reason. It's like kind of Fosamax, the osteoporosis drug, if you're familiar with it. There's a lot of misinformation about it, and the patients, they, in our area, in our region, they do their research and come, right? So they already have read that information on the internet. So your job is kind of like, it's climbing an uphill battle from the get-go, right? Because they already come with a preconceived this thing that, okay, it's not for me. I can try diet and exercise. So I think having those tools for ASCVD risk is important. So yesterday I had a patient we did the ASCVD risk score on them. It was kind of in the category where they would be on statins. We changed their LDL levels on that. It still stayed the same because they're 62. So that was compelling enough for them to say that, no, yeah, I think my age, I cannot change that. So those kind of things we are promoting with our physicians, but it still remains a challenge.
Yeah, and I think the point about calcium scoring as a visual aid to move the needle on patient hesitancy is a good one. That we've talked a lot about in this Right Care before. And so hoping that that'll be a tool that gets used. And I guess a lot of the concerns you mentioned were neurological. And so I'm here to just say it once so everyone hears that, the biggest contributor to dementia that's reversible and preventable is vascular disease. So actually taking the statin would probably help you ultimately. Those studies on cognitive impairment are not really fleshed out. And yes, there are lots of media and some studies that report higher cases of intracranial hemorrhage on statins, but the original landmark papers that reported that, like the Sparkle trial, really were not felt to be the statin at play, but rather the poorly controlled hypertension that was leading to bleeds, similar to how it was leading to strokes that was warranting the statin medication in the first place for that trial. And yes, there are additional studies that do seem to show a very low LDL associated with some increased hemorrhage, but that's when we get to LDLs under 30, which I don't think in the patient that's sort of hesitant is what you're necessarily targeting.
Yeah.
And so most of the neurological complications really don't have any data to stand on. And that's why I think brain, heart, and vascular disease collaborations are so important. So I'm glad that I'm the neurology representative in this group.
Thank you so much. Thanks a lot. And actually, what you said led us to develop some information that our physicians can use to actually quote these studies to patients in a very, simple language or a simple way. So.
Yeah, because of time, I'll give the last question to Bill Baumer, and we might round back up for other people have questions. So, Bill, you want to ask the last question, or you still have your hand up, or? And you're on mute.
I'm unmuted. No, thank you very much for that. I think that's a comprehensive approach. The blood pressure cuff was a certain thing, and yes, any way we can get blood pressure out there for both telemedicine, cuffs at home, and for home monitoring. I think that's a very important thing. And the next step is continuous blood pressure monitoring, but that's a little bit more, that's a bigger step to take for us. And cholesterol control is important, as well as the new therapies for diabetes are very important, and we'll get to see. The percent probably will never be 85 or 90% for GLP-1 and SGLT2s because of additional requirements, including the injection. And the other is SGLT2s have some restrictions and may not work as well for people with reduced GFR. So when the GFR gets below 30, then there's some question, well, they'll work or not. Now, the interesting thing about that is they appear to be renoprotective, and those are the very patients who may have that. So I think that story is still out as to how low a GFR we should go with the SGLT2 at this time. But fascinating, and we've got a lot to learn, so it will be interesting.
And I have to say that I'm seeing more and more of our cardiologists and nephrologists prescribing these medications for patients. So that is very encouraging.
Yes. Well, on that note, we'll move on and go back to the Q&A. Just want to thank, again, Chhavi for this wonderful presentation and a great discussion. So moving along to close out our planned session, I'm pleased to introduce Chris Krawczyk. We had a little debate about how to pronounce his name. We're very happy that he kind of guided us, and he's our Chief Analytic Officer from the Information Services Division, OSHPD, which is the Office of Statewide Health and Planning and Development. And for his fun fact, he was telling us that he's very proud to share he'll be soon to be an empty nester and have more free time. So without further ado, Chris, take it away.
Excellent. Thank you, Edward. And I'm going to go ahead and actually I have to bring up my screen and get my slides going. But want to thank Edward for the introduction. I also want to thank Hattie for the invitation to present today. And it was about a month ago that our office released a report. It's actually a collection of visualizations arranged into a dashboard on some diabetes measures. And it was the release of that report that gathered some attention from the group here today and led to the invitation to come and present. I do want to just kind of say, the report is right now focused on diabetes, but it's what we would refer to as a first generation product. Our approach is that we, put out a product, we then, receive feedback on that product. And from that feedback, we continue to iterate forward to make it a more comprehensive, information tool. So I will, as a part of my presentation today, identify where there are some opportunities to bring in the cardiovascular component of this, but would really be interested when we do get to the Q&A on what some of the audience's ideas are as to how we can take this current diabetes analysis, some of the cardiovascular opportunities, and move towards a more informative, comprehensive tool for you all in your work. I'm going to take a few minutes at the beginning just to give a little bit of a background about OSHPD and the data that we have. And I do so because we do have an abundance of data, and the majority of it is available for use publicly. And what's not available for use publicly, many of you in this audience today are actually eligible to request the data from us and to use it in your own work. And then I'll go into a little bit about the measures that we used, and then the actual diabetes dashboard that we created and that we put out, and I'll include a demo in there. I do also want to just make note that, I will refer to us as OSHPD today, Office of Statewide Health Planning and Development, but we're in transition. So as a part of the current recently passed budget, we are now moving from being an office to a department. And so going forward, we're going to be known as the Department of Healthcare Access and Information. So OSHPD collects data from over 8,000 facilities across the state. And I know that this is kind of a really busy slide, but it does do a good job of sort of laying out what are the different topic areas by which we receive data from those 8,000 facilities. And we do get, data on the workforce. That's actually an area that's going to be expanding fairly significantly, also as a result of the recent budget that was passed. But we have cost transparency data, healthcare utilization data, healthcare quality data, and then also data on the different facilities. A lot of what I'm going to present today is going to really focus on that utilization and quality component of it. We tend to gear our products towards industry. We know from business intelligence that a lot of the folks that use our products are related to the healthcare industry, or their associations, their advocates, their policymakers, their researchers, or their media, if they're not more directly related to the healthcare industry. And so from that, our use cases and what we try to put out is really geared towards those audiences. Although we do have a mind and an eye towards the consumers, we view them as a secondary audience, again, based upon what we know from our business intelligence. So getting into some of the data, I'm going to focus first on our record level data. And there's actually 3 component areas or primary areas. And those are our inpatient discharge data, our ambulatory surgery data, and our emergency department data. And for the presentation today, I'm going to be focusing on the inpatient discharges, but you can see here what's the frequency by which we receive those data, how many hospitals we receive them from, and how many records per year. We also have a couple of other programs, one which Dr. Bomber is very familiar with, actually both of these he's really familiar with, but Dr. Bomber works closely with us on our elective PCI program. And then we also have our coronary artery bypass graft surgery program. And for these, we also receive record level data. Going into just a little bit more detail about the inpatient data, we receive these from all non-federal California licensed hospitals, and there's, it's administrative data. So within there, we receive demographic, diagnostic, and utilization information across 25 diagnosis fields, 21 procedure codes. We've been collecting this data since 1992, and we most recently released the full 2020 data file. Looking a little bit more specifically in here, I just wanted to share this information out so you can get an idea of the type of patient characteristic information that's in there, the types of procedural data that's in the file, and then also the types of diagnosis data, including, again, patient disposition, that's always an interesting one, and the expected source of payment. The emergency department data, similarly, is all non-federal California licensed hospitals, has the demographic, diagnostic, and utilization data. This one we started collecting in 2005, and the most recent file available is 2020. And then the ambulatory surgery data is from, and this is a key distinction, it's from California state license through the Department of Public Health facilities. So this does not include those facilities that operate under the provider license. So it's not as complete a data set as some of our others. Similarly, though, it has demographic, diagnostic, utilization data, and we started collecting this in 2005 and have it through 2020. That is quickly our record level data. It's going to be the focus of what I'm going to be presenting today. But coming back to, again, if you are a researcher, if you're with a California hospital or a business associate of a California hospital, if you are local county government, a health officer, you are eligible to make a request to receive those data. And we will work with you to facilitate access into those record level data for you to use in your own work. The other data I'm going to quickly highlight right here is public information, generally reported to us at an aggregated level by the facility. And it's just, again, to give an idea of the breadth and the depth of the information that's reported to us. So we do get from the hospitals and a number of other settings as shown here, utilization reports. It's a summary report of the utilization of their facility. We get their financial disclosure reports and their utilization financial reports. This is basically they're handing over to us their accounting ledger every year, and then or quarterly, and are working with those data, putting them into some fairly complex pivot tables for, again, use by the public. Then we have a number of other products that are reported to us in aggregate every year. Just some things to highlight on here would be the charge masters, the community benefit plans. Those are always pretty popular. But then also our new our prescription drug cost transparency program data. So we do get reported to us new drugs introduced to market, and we've recently put out some new products related to that and information resources. And then also changes in wholesale acquisition cost over certain thresholds. When these wholesale acquisition costs exceed certain thresholds, it's required by law that those get reported into us, and then we do analyses on those, and we put some information products and dashboards out via our website. That's sort of really quickly the current state of our work. I do want to quickly point towards future. And our office has been very busy developing California's version of an all-payer claims database. We're referring to it as the Healthcare Payments Data Program. And it's basically going to be claims and encounter data being submitted to us across the state. We're estimating that it's roughly going to be about 1 billion claims per year that are going to be flowing into our office. The goal being that this database and this program will be operational by June 30th of 2023. just to give a quick idea of what we do with the data, the analytics that we run generally falls under two broad topic areas. One is the analytics and the reports that we put out related to statutorily mandated reporting. And again, I've shown here some of the products that we put out related to our CABBAGE program, and then also the elective PCI program, which again, Dr. Balmer works directly with our office on doing these analyses for that elective PCI program. But again, we have a number of reporting areas that are mandated that we put out every year. Then we have the collection of other products that we put out, which I would say fall under stakeholder informed or initiative driven. And so every year we do outreach to our stakeholders. We identify what are the topics that are of greatest interest, what are ways that we can grow previous products, as I sort of referred to this generational approach. And those go into a collection of other visualizations and dashboards that we put out, a few of just which I'm highlighting here. We recently put out a series of visualizations under a comprehensive dashboard related to severe sepsis. We put out a series of visualizations that break down patient characteristics and hospital characteristics at the facility level and also at the county level. And then we've also put out the first of our cost transparency dashboards. It's a series of 5 visualizations that look at hospital operating expense, revenues, charitable care costs. We're going to be updating that in the near future with 7 additional visualizations that are going to go further into relating those costs and then also bringing in patient characteristics, facility characteristics, provider information. And this is again all as a result of stakeholder feedback. We also, initiative driven, obviously one of the big areas of focus in the state has been COVID. And so we put out a series of visualizations looking at trends, first by setting. So over on the left here, we have ED, discharge, and ambulatory surgery trends. And you can clearly see that as we got kind of into that, February, March timeframe, there was this precipitous drop in the utilization of those particular settings. The visualization on the right then shows these trends by topic areas. Part of these is focusing on conditions, but another part of it is focusing on key populations, such as persons that are experiencing homelessness. And you again can see a similar drop in the discharge setting. We see this also with the emergency departments. It was pretty much a mirror image of these. And again, hypertension and diabetes are the top 2 lines shown in these. There's another dashboard that shows mortality trends for these different topics. Now, this is partial year data. We now have the full 2020 data, and we're going to be updating this with the full year data and also expanding out a little bit further with the depth of looking at mortality. Based on some of the initial findings that others have reported across the state, but also similarly in some other areas of the country. All of the products that I've shown, either in my feature as a background, but also that I'm going to show related to diabetes, we post the underlying data sets on our open data portal. Actually, every year, OSHPD makes over 100 data sets available on the open data portal. Again, data sets that underlie all of the visualizations and analytics that we've done, but also just some standard data sets. We actually released 15 of these just a few weeks ago to coincide with our having the full 2020 year record level data available for analysis. So I do encourage folks to go to the open data portal and look at what we have available there. And again, it's a great resource that could facilitate your own work, your own research, and your own use of the OSHPD data. So segueing from the background into the measures that we used in our diabetes visualization and dashboard, just going to give a little bit of a background on these. So we use measures that are defined by AHRQ, or the Agency for Healthcare Research and Quality. It's a federal agency that's charged with improving the safety and the quality of America's healthcare system. AHRQ develops knowledge, tools, and data that's needed to improve in these areas and to help policymakers make informed decisions. The ARC quality indicators use the hospital inpatient administrative data to measure healthcare quality, identify areas for further study, and then to track changes over time. These are standardized evidence-based measures of healthcare quality, and that's really important because these are measures that have been rigorously evaluated and have been shown to be effective and high quality measures that can also be standardized to, again, create more of a common dialogue across areas of the state, but also even across the country. And they're used to track clinical performance and outcomes. So these ARC measures are arranged into 4 different modules. One of those modules being the inpatient quality indicators. These are include the mortality indicators and utilization indicators for key procedures that identify potential problem areas that might need further study. This actually is a module from which we draw some of the measures that we use in fulfilling some of our statutory mandated reporting out on performance and performance outcomes within hospitals across the state. There's then the patient safety indicators module. Again, they reflect potentially avoidable safety events that represent opportunities for improvement in the delivery of care from a patient safety perspective. Then there's the pediatric quality indicators. These are specifically tailored to reflect the special characteristics of the pediatric population and identify potential quality and potential safety issues that are specific to the pediatric inpatient population. And then we have the prevention quality indicators. And these are area level, which means that these are not developed at the facility level, but they're developed at the county and at the statewide level that can help to identify where there might be preventable hospitalizations. And they're really an effective tool for community health needs assessments. And this is the module from which we drew our diabetes indicators. So again, the goal here is that it's really to understand where there were preventable hospitalizations, where improved access to care in an outpatient setting and management of chronic disease could prevent the hospitalizations. And so if we were to take a look at these, they're arranged into sort of these different sub-modules. There's the acute conditions, the chronic conditions, and then the diabetes conditions, and then an overall composite across these acute, chronic, and diabetes. Now, within the chronic, you'll see here that hypertension and heart failure are included. We have not put out a product for those, similar to what I'm going to demo for diabetes, but that certainly does present a future opportunity, again, as we think about next generation of what I am going to present with the diabetes measures. What I am going to show with the diabetes measures, though, is the diabetes composite, and then these 4 component parts of the composite. So the diabetes short-term complications, long-term complications, uncontrolled diabetes, and then the lower extremity amputation among patients with diabetes. And I'm going to begin first within the slides, just showing some screen captures of the visualizations that we put out, but then I'm going to switch over to our website and do a live demo of the product. So here we have the first visualization that appears on that website, and it's just a thematically presented map of the state showing for the composite measure where are those areas that are above and or below the statewide rate for the composite measure. And you can see, again, areas down in Southern California through the Central Valley, and then kind of up into the Sutter Buttes and northward that are higher than the statewide average. We pulled out here just to look at some of the counties that Hattie had asked that we focus on. And what you can see is that Alameda, San Francisco, and Santa Clara have a risk-adjusted rate that is lower than the statewide risk-adjusted rate, whereas Los Angeles and Sacramento have rates that are above the statewide risk-adjusted rate. And again, that's also shown thematically within the map. The next visualization is actually a heat table that takes the statewide level and then takes all of the counties and thematically presents their rates for the composite, but also for the 4 individual measures. And again, where are they at in terms of being above or below the statewide? And this is beneficial and important because it does give you a visual depiction of where there are areas in the state that are hotter, if you will, across the component measures. But it also helps to understand that in the composite measure, there might be an area that is doing better than the statewide, but that doesn't mean that there's not opportunity within the specific measures. And a good example of that is Santa Clara, which in the composite is doing better than the rest of the state, but has opportunity when it comes to uncontrolled diabetes and when it comes to lower extremity amputation. Last visualization is actually presenting trend. And the reason that trend is important is because what I've shown up to here is very much cross-sectional using the 2019 data. But when we look at the trend, what we can see is that actually statewide for the composite, we have had an increasing risk-adjusted rate for the state. So, while we might say that a county is doing better than the statewide rate, that doesn't mean that their rate is in the good or has been going down over time. It might actually be going up as well. And that's what we can see here is that not only statewide, but even within certain counties, the trend in the composite is moving upward in the state. So indicating that there is opportunity for improvement. I'm going to exit and stop share on the slides, and I'm going to switch over and actually go to the website now. And hopefully the website is showing. If I just get confirmation on that.
Yes.
It is
Okay.
showing.
Excellent.
Yeah.
So I'm just going to do a quick demo just to show folks how to use the website. It's organized with, again, some background and some narrative, but also a question-based table of contents, if you will, that if you have a particular area that you want to focus on, you can find it here. For example, if I wanted to go right over to the trends, I can click on that question and it'll navigate me down just to that particular area of the website. After I look at this particular area, if I want to go back up to the top and choose a different question, we have that back to top feature that allows you to quickly go back to that table of contents, if you will. But really, it's again organized as I showed in the screenshot. So we have the statewide map here, and one particular feature is that if you were to go and hover over any part of the state, you then get this tooltip that'll pop up and it'll give you an additional breakdown of that particular area. So if I was just to, kind of go over here into the Bay Area, look at San Mateo County or look at Santa Clara County, you can see what was their risk-adjusted rate for the composite measure compared to the statewide, and then actually how many discharges related to diabetes were within Santa Clara County for 2019. And, for example, this is beneficial because if I wanted to go and look up at, say, Sacramento, I can see again, not only the risk-adjusted rate being higher, but what was the actual overall count. And you can see that the count and number of discharges in Sacramento was actually about 600, actually I'm done here, 600 greater than in Santa Clara County. Going to the next area of the dashboard, this is that heat table that I was talking about. And again, it's just a really nice way to get a visual understanding of where are their hot areas of the state, or for example, where are there particular indicators that are being driven by a smaller number of areas of the state. For example, with the uncontrolled diabetes, we can see a lot of blue in here, but then we see a few areas that really light up in red. So again, it's kind of, you can scroll down and you can get an idea of what are those hot spots. And going to the third tool, this is where we've built in some filters. So again, when this one loads, it's going to have the composite, but it's also going to have the entire state and all counties in the state. But if I wanted to go ahead and focus on a particular county, such as Santa Clara, I can go ahead and I can come in, I can turn off all of the counties, and then I can go down here and I'm going to actually choose the statewide so that still is included. And then I'm going to choose Santa Clara. and the visualizational update so that we have that particular focus. And again, as I mentioned earlier, for the composite measure, statewide we're increasing, and Santa Clara is increasing, somewhat similar to the statewide, but perhaps not as dramatic of an increase. But I do want to focus that you can then go in and you can choose the individual measures. So when we look at the short-term complications, again, you can see that there's an increase statewide and in Santa Clara, although Santa Clara's rate still is better than the statewide. When we look at long-term complications, again, similar, there's an increase, although it's not as dramatic in Santa Clara as what we're seeing statewide. But when we get down to uncontrolled diabetes, this is where we actually see that statewide we are improving. So this is good news. And similar to the statewide, Santa Clara is improving. And then when we go to lower extremity amputations, this is particularly interesting because statewide, we are actually increasing in the rate, but Santa Clara is not increasing as dramatically. I would say for the most part, there's a slight 1% increase over the last few years, but it's not as dramatic as the rest of the state. So that is the website. We have additional resources that folks can link to down here. And then also you can go and link out to the open data portal, and this will take you directly to the underlying data for these analyses. If you wanted to go ahead and download it yourself and do your own work with the data, you have that opportunity via that link. I'm quickly gonna just go back to the PowerPoint and wanted to just highlight some additional resources. Again, my understanding is that these slides are going to be available to you all. So here are some links out directly to the products that I demonstrated today. Here's also where you can get some additional information about OSHPD and about our data, or to request our data if you're again in one of those audiences that is eligible to receive the record level data. And so I want to thank you, and I think hopefully at least a couple minutes for questions.
No problem. Thank you, Chris. This was wonderful. It's a treasure trove of information for us data geeks to look into, and look forward to that. And a round of virtual applause over there. I see a question in the chat, which I'll go first, and I'll go to the one that raised the hand. There was a question about explaining the numerator and denominator population for the PQI indices for that composite one, I believe. Could you explain a little bit more what goes into that?
Yeah, so these are risk adjusted. And so first, the way that it works is that we share our data with AHRQ as a federal partner. And then they bring our data in along with data from the other states. They do some standardization of it, and then they return it to us in a what's called a state inpatient database file that has that standardization, but then they also return it to us with some software that has the initial risk adjusted the calculations, if you will, and statistics completed. And so we use that software in order to then, create the measures, if you will, at the county or at the state level. And what's going to be in the numerator, for example, if we're looking at, the lower extremity amputation, are that the patients that did have a lower extremity amputation that were also diabetic. The denominator for that then is going to be all of the patients at the hospital. And so then that will get risk adjusted, taking into account the severity of the patient population that's being treated at that hospital, or actually within that county area, because these are area level. So these would be actually numerator of counts within the county. Denominator is counts within the county, and then it's risk adjusted for that population in that area.
Can you briefly explain what's the risk adjustment methodology that goes into this?
Yeah, so the goal there is that obviously, in different areas of the state, the patient population that is being seen has a greater underlying risk of disease than what might exist in another area of the state. And so the software takes in other conditions, take in other patient characteristics, And then, there's statistics that are applied to create more of an apples to apples, if you will. So a particular area of the state that has a underlying patient population with a greater underlying risk of disease is not disproportionately presented in the data as underperforming, if you will, right? We see it more so at the facility level where there can be, greater heterogeneity in the underlying patient populations than what you might see across a single county. But there is also considerable variation then comparing county to county and the underlying patient populations.
Got it. Let's see. So I think that's Hattie's question, right? She lowered her hand.
And actually,
Yeah.
we do have an infographic that we can also share out to the group that shows what is risk adjustment in a, using an applied case. It's just a single pager, non-technical document. And it shows why accounting for underlying risk is important when, you're presenting these types of statistics. I'd be happy to share that out to folks.
Yeah, I think you would like that. And Hattie, you had your hand up?
I have so many questions, of course, but I'll try to narrow it. I'm wondering, have we answered Keith Emmons' question already, though? I can't remember.
Not yet. We haven't gone to that one yet, which I was wondering which one we've...
I just want to say that one of our co-founders of our Capital Region group, Parag Agnihotri, who's now the head of population health for UC San Diego, has asked and challenged the Right Care Initiative to go beyond those gold bar charts to connecting the performance levels with our control of hypertension, cholesterol, and A1Cs to those very hospitalization rates and actual outcomes, actual event rates. Now, the fact that the medical group performance data is held over at the Office of the Patient Advocate, and you've got the event rates, I think is something that I would just like to challenge you to try to knit together so that we can really drive quality improvement greater for the benefit of patients around the state. The other item is just that we have been depending on your data for so long. And I used to be able to find a report on your website very easily, which maybe you can show us right now, that shows by county the outcomes, the discharge to home, to morgue, to whatever, for instance, heart attacks and strokes. That is really important data. And it's either no longer on your website or it is buried.
Mm-hmm. So we did redo the website several years ago, and there were a number of reports that were moved over to the open data portal. I believe, I'd have to confirm, but I believe that particular report is one of the ones that migrated over to the open data portal. However, this is really useful feedback. If, that type of a disposition summary is beneficial for us to put into more of this dynamic, engaging visualization. That's the type of feedback that we're looking for, and that, we would then build into some of our future product planning. So I thank you, Hattie, for that feedback. In terms of the data from the Office of the Patient Advocate, I would really be interested in just, further dialogue of, what would the connecting of those two data environments, if you will, and views of the healthcare spectrum, what that could look like. Because again, what we've put out is looking at, preventable hospitalization opportunities. And from what I saw, before we started today, what the Office of the Patient Advocate is putting out is very much about the direct patient care in, the outpatient setting. And so how do we bring those two together to show how, for example, a hospital that's in a 70% or above on some of those measures in the OPA, well, what does that, hospital look like when it comes to then the inpatient or even ED encounters in patients presenting into the ED. So I think there's opportunity, but I'd like to engage further on what could that specifically look like.
Thank you. Yes, we would like the document on risk adjustment, so please send it so we can circulate. And there's a question about when will the date or the timing when the full set of 2020 data will be uploaded to the website. Do you know when that will be?
Yeah, well, the 2020 data in terms of analytic files, again, what we put on the open data portal as just, one of our 15 standard data file releases, that's been made available. The 2020 files for example, researchers to request, those are available for that request process. But in terms of the different visualizations, it really is on a flow basis. So right now we are working, for example, on the COVID-related utilization trend lines. That one we hope to get out in the next 4 to 6 weeks, I would say. The diabetes product, because we just released it last month with the 2019 data, it's further in the queue in terms of updating with the 2020. But we also kind of wanted to get feedback on the product before we then incorporate the 2020 data. Because if there is an opportunity to add some other measures into it or to add some other filters, then we'll bring forward that additional functionality as a part of the refresh with the 2020 data.
That's great. If people are interested in giving feedback, is there they can do it through the website, or do we give it to you?
If they wanted, they can give it directly to me. So yeah, my information was actually on one of those resource slides. They can feel free to email me, or the best thing is actually send it to all one word, data and reports @oshpod.ca.gov. And I see some members of my team actually putting info into the chat. So Mary just put that in there. So that is our general email address, and all information that comes into there does get logged and becomes a part of our business intelligence and operations and doing.
So Chris,
Fantastic.
I just want to make an open invitation for you to join us when our leadership gathers every Friday afternoon from 1 to 2. We could find a date that works for you and your team to bring you into our leadership discussion so we could talk about some really useful products. So for instance, I am really hungering for seeing that current hospital discharge data on heart attacks and strokes, because I want to be able to highlight and have discussions with the hospitals that are doing well or aren't doing well, to say you have an opportunity here to maybe work more closely with Palo Alto Medical Foundation, or to be able to catalyze some improvement for patients. So that, the number one killer, heart attacks, the number one disabler, stroke, that should be like really high priority. I know that COVID, of course, is your number one, but let's hear from Dr. Nurali Vora. You look beautiful, by the way, after your hard shift today. So I'm going to mute myself, and would you unmute Dr. Vora, our neurologist from Stanford?
Hi, thank you for that awesome presentation. I'm just like jumping on my seat, ready to check out the OSHPD data, and feel bad that I haven't done it already, but totally agree with Hattie's comments that stroke and heart attacks should get their own menu of questions associated with them when you guys have the manpower to do that. So my original question, and I'll sort of expand on that, is how visible outside of the raw downloadable files are race and ethnicity data, and do you get to the level in your collection of sort of subgroup data for like Asian subgroups or Latinx subgroups?
Great question. And again, typically, as we develop a product and then we put it out, the next version of it, we will take a look at patient characteristics. And so, we do have information on race, ethnicity. We do have date of birth, so we're able to do, age or age groupings. We look at sex. We also look at the expected payer type, and there's always some really interesting findings there, looking at Medi-Cal versus private versus uninsured. And we also have primary language spoken. And, that's not an indicator that we can use in every analysis without getting into, the complexity of all of, again, the standardization and the risk adjustment and how we have to, or how we can or cannot stratify data further. But we do have primary language spoken. And that's a really interesting opportunity when it comes to, again, like some of the early entries into social determinants of health. So we do put filters on our visualizations that will allow you to select different combinations of those. And then again, the visualization will dynamically update to give you the statistics based on what you selected. The data can go into a fair level of specificity using, again, race, ethnicity, but there are limitations depending upon the, sort of geographic level, for example, that we're looking at, with also making sure that we keep privacy at the forefront. If we get down to facility level and we're looking at, a number of, different race ethnic groups, we could get into a small numbers issue, and then we have to de-identify them. So there is there is an additional level of specificity in there beyond just the general classifications, but there's often limitations with what we can present there.
Thanks so much. I think that's particularly important in like our county in Santa Clara, where, each even portion of the county can have really variable, in different zip codes within the county can have very variable outcomes that might not be reflected in the county-wide curve.
Yeah. And actually, and getting to within county, just another sort of future on the horizon, we are working on a regulations package that will, if it goes through, will begin to collect patient address, and we're going to be then geocoding those, getting down to, like, for example, census tract, and then bringing in, one that'll give us, a better understanding of, again, locally, but being able to overlay that with other information, for example, like provider shortage areas, looking at some, social disparity of health indices. So, for example, health equity indices that exist at those census tract levels. And so growing, again, our products in that generationally in that direction.
Thank you so much.
Yeah.
I see Dr. Balmer has his hand up. Dr. Balmer, did you want to express your question?
Well, first of all, a comment and a disclosure. I do work with Chris and his department, so that's a full disclosure, but that gives me the opportunity to say that the people in his office / now department are unbelievably comprehensive in their approach to accessing data. They will go to any corner of the state to try to fill in absent data and get as complete a data set as possible, which makes that a very valuable data set in my mind. And they spend a lot of time trying to work on the statistical presentation of that and the analysis. And so they're extremely dedicated, and every one of them works very diligently to put out a very excellent product. The one thing I do see, though, is that this very valuable tool of this 100 data sets that is out there, I think is somewhat underutilized by the rest of us, meaning that we don't fully appreciate and use these very effective tools, and we need to do that more. So I would like to encourage anyone on the call now, if you have possible interactions with OSHPD, to reach out to them to develop, because we are not using these tools to the full ability that they can produce. And I think that there's far greater opportunity here than has actually been used at this time. So encourage any type of reach out cooperation, because I think that we're missing a little bit by not fully utilizing all of this valuable information.
Yes, and thank you, Dr. Baumer. I really appreciate the accolades for the team that we have here and the information that we have. And again, happy also to orient folks to some of the resources that Dr. Baumer referenced, in particular the Open Data Portal. If we can assist in your use, then please let us know.
Definitely will tick you up on the offer. And again, thank you very much for this engaging discussion. This has been a great program. We're running a little over, but I do want to get back to some of the questions that we didn't get to. And Catrina, if I don't put you on notice, a few questions I want to get back to you. But again, I want to open up for all the panelists over here to be available for some of the questions. So I want to get back to the question that Dr. Keith Emmons asked. And his question is about resources and where to focus. And the question is that I represent a small health plan with a limited budget. Where would I get more return for my investments or incentives to providers and physicians to effect change and improvement based on the data that you've shown? Any insights on that, Catrina?
Okay, so that's a really good question. I mean, you really have to look, I would say, from a population perspective, first look at the population you serve and what resources are already available that are existing that wouldn't cost you all anything to refer the patients to, that are low cost, that may be supported by their health insurance plans, or even that are just free. I know that one of the doctors talked about, recommending walks. I mean, there are some environmental issues and some some air quality issues that may, play a factor into that right now. But when air quality is good, maybe walks are, something very simple that they can do with their family. So then it's not just the individual, but you're changing the household behavior. So I would just say, really look at, what resources already exist within the community, and then just alternative ways to think of interventions to change behaviors, whether it is like a partnership with a pharmacist so that they can identify durable medical equipment, or, medical equipment that they can use that, programs offer it in that area. So that would be my recommendation.
Thank you. Also to you, Catrina, there are some questions about drill down on race and ethnicity data. So there's one comment about, do you drill down to Fiji Indians? And I think following up with Nirali's questions, are you able to drill down to subgroups within Asians and Latino populations? Is that available? Or if not, is there a direction to go there with the data you have?
So for CHIS, that is not an option. They really use what are like the standard population levels, and they just lump them together. So with certain data sets, absolutely, but with the majority, no. Or you'd have to be able to link the data sets. And when I say that, you'd have to link to the American Community Survey, and then maybe find factors where you can link it to maybe like an OSHPD or to the CHIS data, or even to the BRFIS data.
Yes, well, again, data is not perfect, so thank you for that. And I think just collecting better race and ethnicity data is a hot topic right now, how we do that as disparity comes into place. And I know there are analytic efforts that NCQA has recommended, and however the gold standard is patient-reported identification. Again, how do we set up the data infrastructure to collect that in a standardized way that we can use it? I think it's a collective challenge that we have to look into how to solve. I do know that someone in the audience raised a question during Chhavi's Mehta talk, and I still see that person on the attendee list, and I happen to know that person, so I don't mind calling them out. Kim Buss, I noticed that you had your hand up in Chhavi's section. If you're still here, if you want to ask your question, here's your opportunity to do so.
I'm not sure that Kim is able to If she's still on, Jenny, please promote her to a panelist so she could verbalize her question. So let me just see, what did she just have? I think we might have Kim Buss join us when Dr. Jose Arevalo presents on the improvements that they've made at their Independent Practice Association of Sutter up in Sacramento. He and I spoke yesterday, and oh, there's Kimberly Buss. Hi, Kim. Okay, so you seem to be muted.
Oh no, did I unmute myself?
Okay, I can hear you just a
No.
little bit, so be super loud.
Okay, I think it's because of the speaker I'm using. I will try and be super loud. Can you hear me now?
Barely.
Yes, very faint.
I'll try and see if I can change it. My question for you all during Chhavi's presentation was around the cost of some of the medications that we use, especially the SGLT2s and the GLP-1s. And I've been doing polling of providers about that cost. And it seems that one of the big issues is for patients who have high deductible healthcare plans. And I'm wondering, Catrina, if there's any work being done on a kind of statewide level about how to increase access to medications that decrease complications over time, even if they're really expensive, for all the patients, especially on the exchange, who have high deductible healthcare plans. That's my question that I was thinking when Chhavi was speaking. And I was wondering if any of the rest of you have ideas about how to manage that problem.
Okay, so I'll start off first. At the state level, there's not been a discussion yet on how to address like the high cost of medications. But what we have suggested is just the partnership with pharmacists so that we can increase education on medication management. So then like when we're talking about cost for medication, that's more of a health plan and maybe like a pharmaceutical advocacy piece. And we tend to be more on the side of educators.
Any other thoughts people have about how that problem's been issued? I don't know if Dr. Balmer or other folks working in other healthcare systems have been addressing that, especially around SGLT2s and GLP-1s.
So I'll jump in. The first that came to mind is, I made mention as part of my background, our prescription drug cost transparency program, which again was a result of new legislation just a couple of years ago. And again, what gets reported to us that there's, a particular drug that has, exceeded a threshold in change in the wholesale acquisition cost, it's supposed to get reported to us. The open data portal actually has a listing of all of those drugs that are reported to us. And you can go in there and you can sort of, filter out or take out those that are related to diabetes care. And you can actually get an idea of what have the changes been among those drugs. And again, those that have been reported to us. We actually are also, that we're looking at statute, we're looking at what's allowed and what we're authorized to do within statute and also within our contracts. But I'd like feedback on, for example, therapeutic drug classes and how we could perhaps go within the data, identify drugs, bring them in under different therapeutic drug classes, and then do some analytics that show, what are the changes that are occurring? How do they vary? Whether it's, what we would call an innovator or a non-innovator schedule, meaning generally generics or non-generics, but explore with stakeholders, what are some of those opportunities? Again, keeping in mind that the permissions or the authority that we have within statute and contract.
That sounds like a great conversation, and thank you. And I think because Sutter Health is a system that has so many different payers, but yet we're really trying to manage our population, we really struggle with this issue, but especially around medications that we know have the benefit of decreasing hospitalization rates and decreasing the development of chronic kidney disease, which have profound positive impacts on our overarching population over time. But yet we're expecting the patient to really bear the burden of the cost for that, even though it may not really impact their own experience in the short term. So I think this is a really important topic for us to be considering kind of from a policy perspective, and really thinking about how to make that data transparent enough for us to identify when we're kind of causing our own burden over time by not providing access to patients to medications that can really alter their outcomes.
Yeah, I'd say again, if you go to the OSHPAD website, or we can even follow up with you directly. But if you just go and look for CTRX or prescription cost transparency, you'd be able to get into those data, and then even link out directly to those data on the open data portal, where again, all of the drugs would be listed. What was the baseline wholesale acquisition cost? What's the new cost? And what was the resulting change?
Great, thanks. I think your website seems fascinating. Your data source seems fascinating. I think there's all sorts of ways we can think of partnering with you in the work we're doing. So really exciting.
Thank you.
Yeah, I think I see the last one asked question, and I think someone asked about, is there information regarding gender identity of the patients? So do you want to take that, Chris? Is that an element collected and reported on?
Yeah, SOGI, or sexual orientation and gender identification, is an area that in all of our outreach, we're hearing very, very regularly the interest in SOGI measures and SOGI analytics. At present, what the data that we collect is based on either national guidelines or the International Classification of Diseases, so ICD-10 currently. And folks familiar with either the national data collection guidelines for administrative data, hospital databases, or the ICD-10, those data are limited. But there are efforts underway, particularly in ICD-10, to add codes in there that will better enable analyses of sexual orientation and gender identification. So they're not there now. We're hoping that they're there in the future. And when they are there, we have a number of analyses that folks are interested in are doing.
So Chris, I hate to be a broken record, but I would just like to re-emphasize one of our principles in the Right Care Initiative, and that's the law of large numbers. Mm-hmm. So political advocacy groups can ask you to do 1 billion different things, but I would just ask you to add the lens of how many people will benefit from this focus. And I just want to re-emphasize that heart attack and stroke are two sides of the same coin. Mm-hmm. And those two together are the #1 killers and disablers, and at young ages. I could share my screen and show you, but Catrina Taylor has helped us on our women's writing group to look at the CDC Wonder data and look at how in our cultural messaging, we say to young women that breast cancer and cervical cancer are what they need to be absolutely worried about. They need to be getting those screenings. And yet, if you look at your data on what's killing people, if you add together mortality at a per 100,000 basis in the younger age groups where we do not think of heart attacks and strokes for men or women, you start seeing, at least in the 30s, that it is a very large threat to mortality and equal to those things that are in the public eye. So I just hope that you will devote your resources and time to what is killing and disabling people. And I think one of the big problems that we have in our state is we ask the health systems to look at, they make the metrics equal as to what they should be looking at, whereas we should be looking at what is going to take you out of this life. And let's make sure we get those right. So I think that your data support is critically important for that. And I would just once again like to ask you to ask your staff to get that heart attack outcomes data, stroke outcomes data back up front and center on your website. It shouldn't be buried for only researchers to be able to find. And you might be able to show us today, but the last I spent half an hour looking for it. I could not find it, which is, it's just, I could see how that could happen in the redo of the web page, but you have a lot of people on the amazing number of people still with you, 30 people, half an hour after our end time, who are very interested in using data to drive better outcomes for patients and families. So with that, I'll just say that we stand ready to partner with you to help in how to make that data more accessible in more usable ways. You've got Stanford Health with you. You've got the Medi-Cal plan from Santa Barbara County. You've got UCSF, UC Davis, Sutter, Palo Alto, and I can't even name all the people who aren't on the panel here, but
exactly.
we're a robust group of people who are dedicated month after month, year after year, and we completely rely on your solid work. So thank you so much for your incredible attention to detail and sticking true to the science.
Excellent.
So,
Well, and thank you. I mean, again, this is the type of feedback that we want, that we need. Look forward to meeting with, the leadership group and getting, even more specific on some of the use cases. Some of the topics and items that Hattie, you pointed out, or that others, I would say just stay tuned. The analytics is in the works. Actually, earlier today was looking at the initial analytics for a new heart failure product. So we are looking at these topics. We've heard this. We're developing out the analytics. In some instances, it's a matter of, again, doing measure definition. So again, Hattie, as you indicated, that we're getting the right measure that is accurate and is informative and is actionable. Some of the measures that we used previously, Hattie, you mentioned stroke, like one of the ischemic stroke measures that we'd used previously was retired. And so, it's no longer an endorsed measure, if you will. And so we have to turn our attention to, okay, what is that next measure? And so there's some things that are out of our control, but it's not to make excuse. It's to identify opportunity where, okay, what is that measure now? And we can work with our partners and we can get those back up and we can put those products out. So
who retired ischemic stroke, the #1 disabler in the world?
Yeah, it's we have some questions about that as well. So we're working with those partners to better understand ourselves. So.
As we know, work is continuous and quality improvement, and I think again, I think with timing, I just want to say on behalf of the Right Care Initiative, sincere thanks to our superb panel of speakers today, Catrina Taylor, Chhavi Mehta, and Christopher Krawczyk. Wealth of information, and I'm sure the dialogue will continue. Here we are. The next session is coming up in 2 weeks, in September 13th from 12 to 2. On cardiac rehab, stress reduction, and meditation. By the way, I had a preview of that talk. It's absolutely fascinating. And for those of you who have strong interest of looking at non-pharmacologic ways of helping to improve outcomes, don't miss this talk at all. So before we close, any last announcements from the Silicon Valley leadership team? If not, thank you all for staying over time. Great discussion, and have a nice, wonderful Labor Day weekend.
Good night.
Thanks, everybody. That was beautiful. Really appreciate your dedication.
Thank you all.
Good evening, and take care.